Good morning, good afternoon, wherever you are. Welcome to this two-part webinar series on advancing neonatal nursing education in Africa. Special thanks to today's panelists for this partnership between Project Hope, the Council of International Neonatal Nurses, WHO, USAID, and the government of Sierra Leone in bringing this webinar in recognition of 2020 as the year of nurse midwifery around the world. Next slide. My name is Tom Kenyon. I'm the Chief Health Officer at Project Hope, where I have oversight of what we do programmatically, and it's my privilege to serve as moderator today and at next week's session. Please remember at the bottom of your screen to submit questions through the chat feature, and we will address these as best we can at the end. So today in part one, we will cover the rationale for introducing or expanding upon neonatal nursing education in Africa. And then next week at the same time, we will cover specific models of education and lessons being learned. And while this topic has relevance everywhere, we're focusing on Africa being just 17% of the world's population, yet accounting for 38% of global neonatal deaths. So these are the objectives around this two-part series: to increase our understanding of why now when it comes to training a new cadre of nurses to care for sick and low birth weight newborns, which is a relatively new concept among African countries. There are African countries that have done this, but very few. And something where we can learn from each other to lower, I think, what we all agree upon are unacceptably high rates of newborn mortality. So let's begin. This is part one, the overview of neonatal nursing education in sub-Saharan Africa, the need and approaches. We're privileged to have just fantastic presenters today from HOPE, USAID, COIN, and WHO, and I'll introduce each of them at the time they give their presentation. So our first presentation will summarize Project HOPE's efforts to date on neonatal nursing education in Sierra Leone and Malawi. This will be presented by Dr. Caroline Kruger, the Senior Advisor for Nursing Education at Project Hope, who has several decades of experience with nursing education programs around the world. Over to you, Caroline.
Good morning and good afternoon, everyone, and welcome. This is a special time to be together to talk about emerging awareness and models, the experience that we have and others collectively have had, an emerging community of practice for neonatal nursing education and for strengthening neonatal care in basic programs. Of all the interventions of reducing neonatal mortality, we are particularly focusing today on neonatal education and what combinations of support are needed that are sustainable. And we focused on several countries, Sierra Leone and Malawi. But before we get to what we're doing in those areas, we wanted to go over some growing awareness of the need for neonatal education, both at the basic level and at a more institutional level at the higher postgraduate level. We know that the high mortality along the continuum of care has not changed very much. And this is because we've done very well in the global emphasis on maternal care, but less on special care of the newborn, which is resulting in not having a substantial decrease in newborn mortality over the years. And this is because there's major gaps in the care of newborns along the continuum, a shortage of and retention of staff with experience in care of small and sick newborns, rotation, practices of rotation out of newborn units because of a shortage of staff, and poor retention of nurses, and sometimes even very limited pay and opportunities for continuing their education. But there have been some very good collaborative efforts. Networking is increasing, and advocacy for policy change and development is also increasing. We want to share that today. So there's emerging also recognition that neonatal nursing education is important. Governments are recognizing that they do not have a neonatal nurse cadre in their national workforce planning. So there are efforts underway that to include that a neonatal cadre. They're also aware that the short-term training programs that have been offered over the years are making minimal difference in the quality of care and mortality. So they're struggling, ministries, to find the best model, the best answers to their strengthening the basic as well as the advanced nursing education, and developing a new neonatal nursing cadre at the postgraduate level. And of course, because of the lack of data measuring the impact of neonatal nursing specialty on newborn outcomes, that lack of impact makes it harder to advocate for resources in preparing nursing faculty in neonatal specialty areas. In-service programs, they recognize that we need to offer stronger in-service programs for neonatal practice, preceptors, but the refresher courses seem to have a minimal impact, and mostly because they are short, doesn't give enough time. There's lack of experts in the country to help with it. They don't typically cover the whole country, but are more centralized. And there's, of course, just an absolute recognition that there's an overwhelming need for advancing nursing education and special care baby units. It's not uncommon to have 1 or 2 nurses per 40-bed cots in a newborn SBCU. And of course, that is not an environment for future students to learn in. And so working with upgrading quality of practice, which you'll hear about more, is essential. Pre-service programs focus on the mother-newborn dyad, especially the midwifery programs, but less on the newborn, especially in the areas of risk assessment and interventions for the sick newborn. So the current programs are recognizing this and trying to strengthen their knowledge and skills in the area. Current postgraduate programs exist in many countries already, but there are differing models of care. Rwanda, Kenya, Ethiopia, South Africa, Zambia, as well as Malawi and Sierra Leone are attempting to develop certificate or postgraduate or strengthening their foundation basic courses in neonatal care. And that's just beginning, but there is a strong recognition that that needs to be done at all levels. You can't just start at the top with postgraduate if you do not have a fundamental good foundation. So those are the challenges to developing postgraduate programs, because there's a lack of competencies in applying to the development of levels of education that need to be established. And we'll also hear more about that in the next presentation. There's growing experience that over the last 3 years with working with neonatal nursing and newborn programs have given us. We began with the Ministry of Health National Advocacy for improving newborn care in these countries. and initiated large stakeholder groups, and of course involved the stakeholders in universities and schools of nursing professional organizations, as well as ministries of health and other stakeholders. Assessment of needs helped in determining where they had strengths and where they had needs. And there was a long facilitation of a series of leadership meetings and decisions on levels of neonatal training. And what is the best placement of advanced neonatal nursing education to meet those country needs? And it may differ from country to country. For instance, should it be a certificate program for existing nurses? Should we add a BSN program? And what about the master's program and graduate? All of that needed discussion in terms of what resources current programs are already, what they're already doing and how to strengthen them. So the progress that we've seen so far in Sierra Leone has been substantial. We started with the early essential care for back to Sierra Leone, essential care for every newborn, and help them start their first KMC units in the country, and also to support development of special care baby units, and with deployment of mentors to help them do that. At the same time, community mother care groups were developed in districts focusing on home-based newborn care, and we learned a lot from that in terms of the need for primary health care support as well as community support for newborn care. But after a number and series of facilitation leadership conferences on what is the best plan for Sierra Leone, they decided that they wanted to offer a BSc in neonatal and pediatric combined, a baccalaureate program given by the College of Medicine, a more sustainable institution for the country, which to offer an advanced program. Where are we now? We're in the middle of it, really. Faculty need to be prepared. There are few resources at the physician level or nursing level that can teach and mentor, so we need to prepare our faculty and help them with a mentorship program. And also at the same time, look at what is the curriculum, what's in the curriculum, what courses are, how it's structured, and what are the competencies of that curriculum, what should it be. So there's much more to do, but the progress in Malawi has been also in the same continuum. They wanted to develop a postgraduate neonatal nursing program because they already have other postgraduate programs in midwifery and also a master's program in medical surgical nursing and pediatric. So it's a little bit easier for them to, because they have the experience, to develop an additional postgraduate neonatal nursing program. So along with the assessment of needs, looking at their strengths and their resources and health facilities and where students can have clinical rotations, they decided that both the professional organization and the university and Kamuzu College of Nursing decided to offer a BSN in neonatal nursing, and they submitted a concept paper for approval. Where are we now in working with Malawi is, with both countries, is really curriculum development, and we have Jefferson College in Philadelphia helping us with back and forth revisions and drafts of that curriculum, and also faculty preparation and course development through right now virtual methods because of the coronavirus, but with use of in-country resources and expertise to continue the faculty preparation program. And we've learned that faculty need to experience clinical care, hands-on care, before they can really develop a course in neonatal nursing or a structure for a curriculum, an overall curriculum. So the support has but mainly in the areas of facilitating decision-making, working with competencies at the pre-service, in-service, and postgraduate levels, the competencies that we have developed so far, support for curriculum and course development, and faculty preparation along with preceptors, because preceptors in clinical areas are going to be the future teachers also in the new programs. Hands-on mentorship with outside expert and in-country expert to help faculty learn the skills and be able to teach future students. And then continuing to advocate, as we're going to be talking about in the next presentations, on clinical standards and competencies for quality of care, so that a student environment is positive for learning. So there's good collaboration, and I think you'll see that as we work through this webinar in all areas, and we hope this will contribute to a wider global networking and advocacy for neonatal nursing education. Some of the examples of the emerging collaboration, and there's many more, but WHO and ministries of health, universities want to be strongly involved. UNICEF is also involved, as well as COIN, who you'll hear from, and the American Academy of Physicians. And Thomas Jefferson has been with their nurse practitioner program, and a myriad of technical advisors, from practitioners to pediatricians to educators, that have been very, very helpful in this effort, and helping it to be, as strong as it can be and as helpful to the increasing demand from countries in Africa. So at this point, we're going to move on to addressing gaps, and what we do with the next steps.
Thanks, Carolyn. And for making the point, we do make a lot of progress with in-service training, but as you said, it's not sustainable in the long run. There's a constant need because of rapid turnover of nursing staff. And what seems to be needed is nursing leaders who can help transform the system to really deliver quality of newborn care, and to have this as their profession. This can be their lifelong profession. And as we've all seen in making the rounds on these special care baby units, the nurses are there who want to do this work, and they just want to be recognized as professionals in this sphere, and we need them to transform the system. So our next topic is around addressing these gaps in neonatal nursing as an imperative to reduce neonatal mortality. And we have Teresa Shaver and Dr. Leah Greenspan-Hoder from USAID. And USAID, of course, has done so much over the decades to improve maternal and newborn outcomes through their many development projects. So Teresa Shaver is the Senior Maternal and Newborn Health Advisor at USAID. She's been involved in, she's a nurse midwife herself and has been a real leader in this topic for more than 30 years in developing alliances to reduce maternal and newborn mortality, especially alliances around this being a human rights issue, and women and babies have a right to this type of care. And she'll be sharing the presentation with Dr. Leah Greenspan-Hoder, who is a board-certified pediatrician and neonatologist. He's the senior newborn advisor neonatologist at USAID, has been working in the DC area for over 20 years as a neonatologist. She's worked extensively in Africa and Asia to build the capacity of health professionals to deliver quality care to small and sick newborns. Over to Teresa and Leah. Thank you.
Thank you so much for inviting us. On behalf of Teresa and myself, we are honored to be part of such an important webinar to improve neonatal mortality across the globe. And the only way to do this is to address the gaps in neonatal nursing. It is imperative that we switch our focus so we can improve neonatal mortality and morbidity. Next slide, please. Survival of the small and sick newborn is the most important item on the unfinished agenda for ending preventable child deaths by 2030. Every year, 1 million newborns die on the first day of life, and 2.5 million die in the neonatal period, not including the 2.6 million babies who are born at stillbirth. Neonatal mortality accounts for 47% of all deaths in children under 5. Progress has been made in reducing deaths in this age group, but neonatal deaths see a much slower reduction. Thus, they comprise a large portion of the deaths. Deaths around the time of birth in the first months of life. Most newborn deaths and disabilities are preventable. If you look on this slide, the main causes of neonatal mortality globally is preterm birth complications, intrapartum-related events, and newborn sepsis. Caring for the small and sick newborn is crucial for reducing death, disability, stunting, and long-term risk of non-communicable diseases. 30 million small and sick newborns worldwide require care in hospitals, with 8 to 10 million needing intensive care in order to survive. By transforming health systems to provide high quality of care for newborns, we will be able to prevent disabilities, optimize child development, and increase lifelong human capital for millions. Next slide, please. Next slide, please. The Sustainable Development Goal 3.2's target is to end preventable deaths of newborns and children under 5 by 2030, with all countries aiming to reduce neonatal mortality to 12 per 1,000 live births. 98% of neonatal deaths globally occur in LMIC, with 78% in sub-Saharan Africa and South Asia. For SSA and South Asia to meet the 2030 goal, they must at least double their current rate of progress. Countries that are least likely to reach the targets are those affected by humanitarian crisis. If we continue at the current rate of progress, South Asia and Sub-Saharan Africa will reach the SDG targets at 2042 and 2050 respectively. But it will not be until the next century before newborns in Sub-Saharan Africa will have the same chance of survival as the newborns in high-income countries. This is demonstrated very clearly in the slide that you're looking at as of now. For countries that are on the path to meet the SDG targets, this has been achieved by addressing neonatal mortality as a continuum of care, investing not only in newborn care, but in obstetrical care, and providing high population levels of intensive newborn care. To provide this high level of care, systems must invest in this specialized healthcare providing. Next slide, please. As you can see on the next, so over the past 20 years, we have seen a shift to facility-based births, with 80% of births now occurring with a skilled birth attendant in most hospitals, with the fastest change in LMIC. So why are babies still dying? Because mothers cannot access care or are delayed in care or are not receiving quality of care. The greatest potential for rapid impact in improving newborn lives is to ensure hospitals are equipped and ready to provide quality services. Quality care requires an integrated, resilient health system, multidisciplinary teams, and innovation. WHO's Quality of Care Framework outlines the key components of quality of care, starting with the health system and moving to provision of care, as well as experience of care. As you can see, quality of care requires an investment not only in numbers, but in skill of healthcare providers. This echoes what was previously mentioned. Shortages and inequitable distribution of competent, motivated health workers, heavy workloads, staffing ratios, and gaps in effective coverage all lead to poor quality of care. Next slide, please. And over to you, Teresa.
In the next slide, you will see that we have the big message here is the global shortage. 7.5 million nurses, and with 89% of the gap in low and middle income countries. Inpatient care of small and sick newborns requires a continuous service delivered by a multidisciplinary team, and we'll talk about that more as we move forward. It's very critical that these providers have and are equipped and trained and have the competency for specialized skills. In low and middle income countries, this level of care is often absent, and there's significant gaps in the health workforce. Safe staffing levels, patient ratio, skill mix. In most countries, regardless of the level of care, nurses and midwives provide most of the critical hands-on care of our most vulnerable, women and newborns. Research studies show that small and sick newborns survive in the facilities is closely linked to the number of qualified nurses working per shift. And as we can see so well presented, and this is from the State of the World Nursing 2020, that we will not meet the shortage by 2030. So with the next slide, in addition to the workforce numbers, we must address the need for a specialized workforce. Being trained myself as a neonatal intensive care nurse, first, before I became a nurse midwife, later many years, it's really important that these skill sets are very, very different. You need both, and you need a team that works together. Those skills need to have competencies, refresher courses, training, and hands-on experience. There's gaps in the quality and equity as well as sheer workforce numbers, as we know. So we've got to be innovative. We've got to examine and put in place, as was mentioned earlier, a gradual advancement, certification, licensing, according to the HR needs in the countries that we work. We've got to take a multidisciplinary approach, and you will hear Leah and I echo this throughout, in working across the continuum of care. We've got to develop a human resource policy and regulation processes that is led by national governments. Leah?
So let's talk about the gaps in care. Often nurses and midwives are inadequately trained and inadvertently provide care that is harmful. Shortages of qualified health workers and inadequately trained and skilled. There's a shortage of qualified health workers and inadequate training and skills for the care of the small and sick newborn. These are major reasons for poor progress in reducing neonatal death. So poor quality of maternal and newborn care is associated with poor implementation of evidence-based interventions closely linked with lack of resources, lack of leadership skills, as well as factors such as cultural, literacy, socioeconomic status, and nutrition. Nurses or midwives with skills in critical areas such as resuscitation, kangaroo mother care, safe oxygen management, and breastfeeding support are the frontline worker for newborns. Yet in the whole of sub-Saharan Africa, there are limited training courses that are specific for neonatal nursing. Urgent systematic attention is required to address lack of training at the pre-service and in-service level, decreased rotations of nurses with skills in neonatal care, deficiencies in workforce numbers, as well as hesitancy in providing care from a multidisciplinary approach. There is gaps in monitoring and evaluation in the impact of the current programs that exist. Next slide, please. When Teresa and I were asked to participate in this webinar, we felt we wanted to model how we work seamlessly together and how much better our presentation and the work that we do directly affecting small sick newborns is affected by our collaborative multidisciplinary approach. Teresa as a nurse and midwife and myself as a neonatologist work best to create improved care. So, defined by the best practices innovation collaboration of the Institute of Medicine, we see the team-based collaborative care as a delivery of health services to individuals, families, and/or communities must be done by at least 2 healthcare providers who work collaboratively with patients to accomplish shared goals and achieve high quality of care. In order to provide the necessary mix of skills, core multidisciplinary teams should include both pediatricians or neonatal doctors, nursing assistants, and other support staff working along qualified nurses and midwives. Though this is difficult to imagine where we stand today, but going forward as we go into the small and sick newborn, we must look at a wider multidisciplinary team that should include other healthcare providers such as nutritionists, dietitians, lactation consultants, speech therapists, and so on. Next slide, please. And to you, Teresa.
So the regulatory processes were touched on in the earlier presentation. There's some important areas that we could all work towards and collaborate on. Registration and licensing, external evaluation and accreditation, clinical governance, training and supervision of the workforce, inspection of institutions for minimum safety standards, safety protocols and checklists, and adverse events reporting. You may be familiar with the maternal and perinatal death surveillance and response, but this has got to be done in a safe, supportive environment without risk of punishment or being ridiculed. And it really requires active participation and supervision by professional associations, which also need to be supported and strengthened. The next 2 slides that I will be addressing, I'm very pleased, is just a small look into a document that Ornella will be talking about shortly. It's the HRH strategy and options to improve newborn care in low and middle income countries. WHO will be coming out with this document, and we hope it'll be used like a roadmap to help us in dialogue with policymakers, with governments, with professional associations as we move forward. This is one piece in this document that will come out that is really well laid out. So when we're talking about policy at the national and subnational level, we need to improve, as was mentioned already, pre-service programs, build the capacity of an existing newborn care providers, upgrade existing cadres, create and train a specialized neonatal nurse, which is different than a regular nurse or a midwife. These are special skills for small and sick newborns with the competencies that are required for that. And the other part of this is, if we look at the HRH actions, it's really important to standardize neonatal care provision, establish recruitment, motivation, and as was touched on before, retention, develop and staffing skill mix, strengthen the HR planning and policy and regulations, and invest in funds for neonatal capacity building. So in summary, we need strategies, interventions, collaboration, accountability, leadership, and governance. If Leah and I can leave you with a few points that we've been trying to emphasize, and there will be a theme throughout the webinar, is nurses specialized in neonatal care require a broad range of skills. Newborns and their families have the right to receive these competent care. And you can look on the WRA White Ribbon Alliance website for an advocacy for respectful care for small and newborn. We need to improve the care. We must address the issues surrounding the workforce crisis, as well as, again, multidisciplinary approach. Build the capacity of neonatal workforce through training and mentoring pre and in-service staff. Scale through developing in-country facilitators, and as mentioned, create a sustainable workforce and collaborate with ministries of health, local actors, partners to develop regulatory processes and policies. Our departing message, and I think you've heard this throughout, it is possible, it is achievable, but it is going to take a coordinated effort between governmental, non-governmental organizations, private, semi-private education, healthcare institutions to scale up and invest in educating and hiring neonatal nurses. This is literally imperative for us to reduce infant mortality. And we can collectively do this, but we need to act now. Thank you.
Thank you, Teresa. Thank you, Leah, for making that strong case around the workforce, that this is something that needs to be led by national governments, but also making the point this is an urgent issue. We need to keep moving as we've been moving, and AID is led on this in-service training and other aspects of health system strengthening, but we also need a more permanent workforce, a more leadership workforce. And to give people an idea of how brisk an issue this is, during the course of this webinar, an hour and a half, some 440 newborns would have died around the world. So this is a very real and active process as we speak. Our next presentation focuses on neonatal nursing education itself in Africa. This will be presented by Dr. Carol Kenner, the CEO of the Council for International Neonatal Nurses, or COIN. And move the next slide, please. Dr. Kenner, in addition to being the CEO of COIN, is also the Dean and Professor at the College of New Jersey School of Nursing, Health, and Exercise Science, where she's dedicated her career to nursing education and the health of neonates and their families. Over to you, Carol. Thank you.
Thank you so much. It's an honor to be part of this presentation and most important work through this webinar series. I want to give you a little context about COIN and how we're working with other organizations, all of the ones that are part of this presentation today. COIN was incorporated in 2005 and represents nurses from over 60 countries. While we have 16 national organizations, we have representatives in each of the 60 countries that are a part of us. Why is that important? Just for the very reasons that we talked today so far in the two previous presentations, that we have to come together as a neonatal nursing community to talk about the challenges as well as the opportunities in neonatal nursing and in making a difference as far as neonatal morbidity and mortality. It's really today to focus on the African, sub-Saharan African countries and what we've learned from each other as we have taken the perspective, such as my perspective from the United States, and from New Zealand, Australia, the UK, and other countries that have experienced a growth and a recognition of neonatal nursing, and taking that to our African colleagues and working with them to raise the voice of neonatal nursing. As far as the overview, I want to put neonatal nursing education and practice in sub-Saharan Africa, the assessment of what we found. Also talk about competencies. You've heard that word throughout the last two presentations, but that really is the framework that COIN is working towards to underpin neonatal nursing education and practice, and also to touch on what Carolyn said in the first presentation about the pre-service and postgraduate neonatal nursing needs and how that fits into the continuum of care. So a situation overview on the next slide shows that neonatal nurses do not have specialized training and education in many countries. But we know from the United States perspective and from the work that really started in the early 70s, that as we got more uniformity and specialized training for those of us, and I was working in the 70s, so I was one of them that came into a neonatal unit and had very little education about newborns. I learned from the orientation and from working in interdisciplinary teams on the job, because at that point in time, just like in Africa at the moment, we didn't have standardization about what a nurse should have in terms of training and education coming into work in the NICU or continuing to work in the NICU. Many nurses that work with small and sick newborns in sub-Saharan Africa, just like in the United States in the 70s, had little or no formal training. And in our nursing programs, and I can still say that as a dean today, our basic education programs, even in the United States, really have very little information besides healthy newborns, the birth of a premature infant, and the mother-baby dyad, not about really small and sick newborn care. So that still is a gap in the United States, and certainly is in Africa. The other part that makes it difficult for neonatal nursing is that we're such a small specialization. We're not as large as a pediatric nurse, an obstetrical nurse, a nurse midwife. So there's a lack of recognition by governments, by many institutions, in where sick and small newborns are actually cared for, that neonatal nursing requires a special body of skills. That in our nursing programs, as Carolyn presented, there's a lack of uniform educational standards that include competencies. And there's a lack of political power. And what I mean by that is that many nurses, this is where the leadership piece that Teresa mentioned, Lee mentioned in the last presentation, that nurses haven't learned in many countries how to use their voice to describe what it's like to provide care on the front lines. That's political power too. It's not about holding a governmental office or being in the ministry. It's about not using that voice to even affect change sometimes in that institution where they work. The emphasis is still on maternal health. Obviously, that's really important. And the small and sick newborn and the need for neonatal nursing as a specialty often gets lost in the mix. So COIN recognized in working with our African partners that there was a need for this consistent competency-based framework. This is what we used in the United States. This is what we used in many higher income countries over the course of many years to improve health outcomes for babies, but also to improve our educational programs and improve our practice. These COIN competencies and the competency framework are in open access. The whole article describes the various levels of competencies. We use the Patricia Benner model of novice to expert, and we framed it around 5 areas: clinical practice, professional ethics and legal practice, the leadership and teamwork that's critical, as well as family-centered developmental care. We recognize that, just as Teresa and Lee presented in the last presentation, that there has to be quality. And quality and excellence in care is only going to come when you have identified competencies and an identified framework. So in the next slide, I gave an example of one of the novice nurses' clinical practice, the standard. What is the standard that we expect of a new nurse that may be working in a unit or walking into a unit like I described myself, with little or no background and requiring education and training? The standard is using theory, research, evidence, observations, and experience in clinical decision making. That standard stays no matter whether you're a clinical novice or whether you're an expert. It's going all through the different levels. The standard doesn't change. The next competency actually stays pretty standard. It practices within agreed parameters, applies knowledge, uses clinical judgment and a range of skills to provide safe and effective care. So if we go and then look at the novice and how that's demonstrated, again, it can be attending neonatal orientation, training sessions and lectures that demonstrates that you're actually gaining that knowledge that is about the small and sick newborn, and beginning to articulate an understanding of neonatal physiology and anatomy so that you know what you're looking at, that you understand what is a problem with that baby. I used to teach the anatomy and physiology and pathophysiology for a number of years of the neonate, and understanding what do you anticipate might be the problems of this baby, and then developing assessment skills. So at this level, you're just beginning to understand the differences between a healthy baby and a sick and small baby. In the next slide, I showed that you've got a competent level nurse. So as I mentioned before, the standard stays the same. The first competency stays the same, but then it's maintaining the ongoing knowledge of neonatal, the neonatal knowledge that you gain through your orientation, through understanding anatomy and physiology, through your experiences now in doing health assessment. And you build on that in that competency, and you're beginning to show much more about what and how you're applying that to an individual case, to the babies that you're taking care of. So it's still that leveling. What do you expect now? Now you're really implementing the knowledge. You are really providing more hands-on care and assessments that are more detailed, and you continue to build throughout to get to the expert level. This is also means that we must transform the care to an informed approach that's on the next slide. It requires the advocacy of nurses that get this training, even at the novice level, beginning to push the institutions to say, I want more knowledge. We have to make a change. We have to have evidence to support our care. It can't be just care as we provided it before. This requires the adoption of the standardized competency-based curriculum. And when I'm saying competency-based curriculum, that can be your orientation program. That can be what we use in the United States perspective, and we're now trying to apply in Africa, the continued competency. How do you demonstrate to others, to your nurse manager, to the neonatologist that you work with, that you are actually moving up in your level of competence? And that's because you start evaluating nurses on that competency level. You start seeing what they're able to do. This also requires collaboration with other professional organizations, just like the ones that are here on the call, as well as WHO, USAID, other professional organizations, ICM, and the governmental organizations, as well as parent groups. It requires also nurses to attend meetings like the WHO, USAID meetings, but in Malawi, but not just about attending, but bringing the stories and the voices of what we need in terms of our educational programs, the competency framework, and discussing why that's important also to be in our nursing education programs. Those same competencies will drive what kind of specialized education that we provide. It drives what your neonatal courses look like. And it also is important that, as I keep saying, that we have to describe that nursing perspective and what it's like, what the gaps are, like Leah presented before, the gaps in the knowledge, the gaps in our educational programs, and then the gaps that we see in practice from the neonatal nursing perspective. In Rwanda, in the African Rwanda conference, we found from a research study from Chiesi Foundation that many of the nurses had no in-service training, really, no training in resuscitation, had not had the opportunity to have formalized training programs and really wanted that. Also were not able to start resuscitations, for example, without, even if they'd had training, without a doctor saying that they could do that. That delayed care. We found that the knowledge and skills became important to nurses, and yet they were not always afforded the opportunity to gain that knowledge and that skill. That's what COIN is trying to do, is work with our colleagues and work with Project Hope, work with USAID, work with WHO to bring that to the forefront, that nurses need the education in their pre-service training, in their educational programs, and then continued education in the unit, and an ability through consistent standardized standards and competencies to demonstrate how they're growing from that. We always say at COIN that you can't run solo. One person can make a difference, but two can really change the world. And we have to bring the differences and our strengths to the position. When we work with African colleagues, it's their boots on the ground. It's their grassroots understanding of what they're facing that we must hear and see how we can bring organizations together to work to strengthen their position. It's a team of rivals approach, which really says differences in how we approach things. A doctor approaches care differently than a nurse approaches care, or a midwife. We need all of those voices to come together to standardize the neonatal side and neonatal nursing approach to care. We must compromise and then move forward to make a difference. So the vision that we have worked for a number of years is COIN contributing to the Every Newborn Action Plan, a world in which there are no preventable deaths of newborns or stillborns, where every pregnancy is wanted, every birth celebrated, and mothers and babies and children thrive and reach their social and economic potential. That will only occur if and when we have better educated, better trained nurses that are recognized as a neonatal specialization, recognized, as Carolyn said, and others, then and Teresa, that it might be through regulation, through licensure, but certainly through competencies. We've seen that make a difference in the United States over the course of about 30 years. We've certainly seen that in other countries, and we need to apply that same principle to the African communities. The nurses are ready and willing and want to provide better care. They are frustrated that they don't have the opportunities to gain the knowledge that they know they need in order to provide that care. And so now is the time, with all of us coming together and through this webinar series, to really think differently. What's the future? We can dream big. We have to think teaming, and we have to involve nurses and provide leadership and help them gain the leadership skills to make a difference more of a difference. They're already making a difference, but making more of a difference in newborn outcomes. Thank you.
Thank you, Carol, so much for that terrific overview of the educational aspect and your enthusiasm, you know, as a neonatal nurse comes through loud and clear, even as a dean of a large training institution. And for making the point of this team approach, not only at the clinical level between pediatricians or neonatologists, if we have them. As we know, very few countries have neonatologists. So we have more on this call than many countries have. But it's a team approach, but we also need a team approach as organizations, as you and others have pointed out. Yours is a specialized organization around this issue, neonatal nursing education, and we need specialized partners like yourself who really have the rich experience and expertise that we as international NGOs can tap into as implementers and look to AID and WHO for their leadership. So thank you very much. Our final presentation is on the roadmap to the human resources for health options, and we emphasize options. There's no one way to get there, but overall we want to improve newborn care in health facilities in low and middle income countries. Our presenter is Dr. Ornella Lancetto, the Senior Medical Officer for Newborn Health at WHO. Dr. Lancetto is a pediatrician and neonatologist whose career has been devoted to advancing newborn health globally, especially taking this on as a public health issue in addition to being a clinical issue. And at WHO, she leads and coordinates WHO's activities around the Emergency Newborn Action Plan, or ENAP, and also WHO's policies and guidelines on newborn health that we all look to. So over to you, Ornella.
Thank you. Good morning, good afternoon. It's my privilege to be with you today to present our roadmap, which is still in draft, on human resources for health strategic options we are still discussing for improving neonatal care in low and middle income countries. Next. And next slide, please. And so we think we are developing this roadmap because we think it's really time now to invest in neonatal nursing, and I'm really happy to hear the same through this webinar. And the idea is to provide with a roadmap, a framework, and also strategic options for countries so they can transform their human resources policy and prepare the healthcare workers with the knowledge, the technical and behavioral skills to ensure quality care for all newborns and reach in this way the targets of 2030. So is a roadmap that has also recognized the value, I mean, the importance of investing in human resources if you want to reach the universal coverage and SDG targets, but also important for transforming how we provide neonatal care in terms of being more family-centered and based on rights. And is also an opportunity now for saving lives, because we have many more women who are delivering in healthcare facilities, and not only saving lives, but also preventing disability and promoting equity. So we are really, next slide, we are really working on what could be done in this area. We identified 10 strategic options, and that are divided in 3 main groups. So the first line is on the training options, and I will go more in details later on. Then there are 5 options for strengthening the healthcare provision, but from the national and subnational level, if you like. And then the last strategy is more for the global level, and I will go in detail later on. So go next. And why now? is certainly important now because finally, after many years of advocacy, we have a number of strategies that recognize the need of advancing on neonatal health. And we have finally also a target, which is a reduction in neonatal mortality rate at least at 212 or less in every country. And this indicator is reflected in the Every Newborn Action Plan, in the Global Strategy for Women and Children and Adolescent Health, in the SDGs, and also in the Global Action Plan for Universal Coverage. But it's also a good time now because we are trying to advance with some of the recommendations that we have put on the report Survive and Thrive, Transforming Care for Every Small and Sick Newborn, recognizing the importance of investing in this particular area of work. And as well is important this year because it's the year of Nurse and Midwives. So next slide. Through this roadmap, our main goal is to strengthen the provision of facility-based nurturing care by competent care providers across the different levels of care, because we also try to promote better standardization of care in order to have a maximum impact on not only survival, but as well as the well-being and development of the child. With two main objectives. One is to improve the number and competence of care workers to deliver essential newborn care and care for small and sick newborns. And the second is to address the special gap in health workers with specialized neonatal skills in low and middle income countries for making them for addressing basically the need of improving quality of inpatient care for small and sick newborns. Next. So the first group of strategies, these are the the block of options that countries can take at national and subnational level in terms of training programs. We identify four main options, so that actually they can go also like in terms of steps in this case. So one is improving and standardize the neonatal content, curricular competence development in the pre-service programs. The second is the building capacity of existing healthcare providers. This is a very important step actually. The third is upgrading the existing cadres with specialized neonatal training, providing also certificate recognition. And four is for countries that are more advanced with their tertiary level care services to create and train a new specialized neonatal nurse. And then we can go with the next slides where we can unpack a bit what are the actions that can be taken under each of these strategies. So on the pre-service programs, there are many options, activities that countries can take, but certainly they need to, we think it's important to review the education, the pre-service education programs. And this is true for the course, midwifery courses, the nursing courses, but also for medical, even for physicians. Sometimes in many countries, the program on neonatal health is very limited. Then it's important to identify those topics that have been neglected. For example, I don't know, kangaroo mother care, the importance of neurodevelopmental care, pain management, and things like that. It's important to standardize also the requirements for pre-service training and encourage the educational institution in working with the professional organization as well in facilitate and promote interprofessional learning. And then last but not least on this, especially now that we are struggling so much with the COVID pandemic, but not only because of that, is the option of the activity of in investing much more and try to take the maximal advantage of digital technology and innovation in training. And this means also distance learning and partnering on this. Next. The next strategy is on building the capacity of existing healthcare providers, and this is an important step because to ensure that not only building capacity but also ensuring that existing providers keep their skills and then the competency up to date as evidence change. So again, there are many, as you can see here, 12 options, so 12 opportunities that people can take and think about going from providing clinical guidelines and standards to neonatal care facilities, provide support to healthcare workers with the decision tools and job aids, to more specific on-job trainings that could be done in different ways, as we know, but also improving providing, institutionalizing the in-service training and even establishing mandatory continuing professional development requirements for the staff who are working in the neonatal unit. Provide mentoring, orientation program mentoring, and there are many type of ways of doing that. And very important also, institutionalize quality improvement approaches. So quality of care can be improved progressively. So, and establishing standards, and finally also consider the rotation of, reduce the rotation of, in this case, consider the rotation of specialized of staff who are working at lower level facility to higher level facility on rotation for acquiring more skills. So on the next slides, focus on the strategy that is more on upgrading the existing cadres with the specialized neonatal training, which then can provide also a qualification and a recognition. And this can be done in several ways by topping up courses of, depending on the country, of 3, 6, or even 12 months. Specifically on neonatal programs. And then it will be important also to establish competencies-based specialist training for these care workers to complete the qualification or to get a certification based on standards that can be national or international. It will be important also to ensure that there is an accreditation for these workers, and their job description is updated and recognized, and possibly also with a step in salary and remuneration. And another important aspect that countries should take into account when moving in this direction is to establish linkages between the teaching and clinical care facilities. So it's not only the theory that, or only the practice that the person learns, but it's a good combination of knowledge and skills. And finally, also countries should consider training requirements for support, for other supporting services, other people, the staff in the multidisciplinary team. And the fourth strategy in the next slides is on is more for those countries who are planning to develop neonatal intensive care units, and are a bit so more tertiary level kind of units, and they can at this point take these steps and create and train a new specialized neonatal nurse cadre. And this has to be based on, maybe the vision in expanding the services, as well as the resources that are available, both for the training, but also for supporting a conducive environment for this staff to be able to work. So again, it requires a national policy with the definition of the scope of practice of this new cadre, the regulations for integrating the cadre into the civil service structure, And another important step is assure that accreditation by the national authority, establish again a competence-based pre-service training curricula for this specialist cadre, which should be based on national and international standards possibly, and review the selection criteria. So the students will meet also the desired deployment goals, and establish linkages between teaching and clinical care facilities as in the previous strategy, and review all of the process, the deployment, to ensure that standards are in place for licensing of these care providers to practice. And because, I mean, there are all these elements that need to be in place to ensure that, when we create this cadre will be in the best position of practicing. And then it's also important to ensure that this cadre will be able to continue in their education and have access to continue education, and in some countries can consider as well as direct entry program. This type of providers are those who might become also the supervisors of and the faculty and the supervisor for those providers of lower level facilities as well. Next. Now we have in the next slides a group of strategies that are more intended for a national and subnational action to support the neonatal care provision. And this, we don't have time to go in detail here, but are very important to complement the training program. So one is to standardize the level of neonatal care provision, because we have learned from more developed countries that is important to create a network, regionalization of care and networks of care to be more effective. Then another strategy is to establish health workers recruitment, well-being, motivation, and retention strategies, because motivation and well-being of a care provider is essential to ensure quality of care. So we need those intervention also in place. Then an important strategy is also the one that is looking at the effective staff ratios and skill mix at the point in the local health facilities. We know that neonatal services need to be operational 24 hours a day and for every day. And so it's very important to have good staff ratios that are calculated based on the workload, on the type of babies that are admitted, and also on the level of care. And we know how difficult it is to ensure this, and how many of us are working with very inconvenient staff ratios. Then another important strategy is strengthen national planning policy and regulations, because of course we need plans that allow us to recognize the importance of developing the neonatal services, and these plans need to be financed, so we need sufficient resources for them. And finally, global level, as mentioned also before, is important to promote global strategies that will support collaboration, will support also national leadership and accountability and governance. And this strategy need to be as well, the global efforts need also to facilitate innovation and multi-country research and learning networks. Then, next. In conclusion, I would like to say that it's really time that to invest in neonatal nurses, and we can, as you know, we have multiple strategic options that countries can take. So we don't have to become discouraged or disheartened by the huge gap that we are facing, but step by step is possible to strengthen this area of work. And the capacity building is certainly starts with the pre-service, but must continue with the in-service learning and career development and recognition of neonatal nurses. There are a number of important options that we have to improve the service provision at different levels, and starting from the national and subnational levels in countries, but continuing also with advocacy and action at global levels. So we will continue to build the country leadership and the capacity in neonatal nursing through collaboration, partnership, but also research and innovation. And for the roadmap, our next steps are to finalize it in the coming month, probably launching it near September with our key partners. I hope you will be with us. We will disseminate and hope to work with many partners for the implementation, and particularly to work in countries to assist countries and support them with the choices they can make based on this roadmap. And then, of course, we want to document and share best practices and monitoring the changes, so data can be used for and lesson can be used for advocacy and additional policy change. Thank you very much. Sorry, I was trying to be very fast, and I look forward to work with you and also to the discussion in the time that is remaining for us. Thank you very much.
Thank you. That was perfect, and thanks for laying out all the strategic options that WHO is proposing, and thank you for sharing this ahead of your release, which I know is often a sensitive topic in organizations, and showing that this is not really a cookie cutter approach, that there's many different approaches that we can take simultaneously, but ultimately we do need this specialized cadre. So I think now we have some questions. We have about 10 minutes. We'll get to as many questions as we can. Ones that we can't get to, maybe we can take those up a week from now when we get into the greater details about implementation options. And there was one point raised that we didn't have African colleagues on the sessions today, but that will be different next week as we get down to the country level and their experiences. So the head of the College of Medical Education and Allied Health Sciences from Sierra Leone will be a presenter next week. Our first question is around faculty preparation and mentoring, and I know this is a big topic for the educators on the group, and maybe I could ask Carol or Carolyn to reply. How are they being prepared and mentored, and how are you training the trainers? You know, how do you start to train a cadre that you don't have yet in the country? And you have experiences with that. Over.
So this is Carol. I know Carolyn is working very closely, as she mentioned on her slide, with Thomas Jefferson University here in the United States that has a neonatal nurse practitioner program. And so we're using the mentorship model for those of us that, like myself, that didn't have the opportunity for the first few years of our own education to get that training. We went back and got training when it was available in the United States and other countries. So we're using those people as mentors to teach other faculty of how to teach the nursing. Carolyn?
Yeah, we have two levels. The first is a phased approach, beginning with very essential newborn care, assessing where the designated faculty are and what their needs are. And then with each content area, which is more in a seminar approach, then ideally they go to the clinical areas for newborn units, and they actually do bedside bedside nursing under the mentorship of an expert that's from developed countries, either Australia or United States, and that worked fairly well until we had the closure of borders under COVID, and now we are looking at ways in which we can provide the mentorship with existing in-country sharing of expertise. And that's going to be an innovative process ongoing. But then not just the content and the state of the art and the competent, levels of skill, but also its course development, its understanding of the competencies at each level, whether it's baccalaureate or master's. And then when they begin implementation of those courses, they're also going to need support for the resources that they need to use, as well as the teaching seminars and the planning for clinical education of the students. Over.
And Carolyn, could you elaborate, because of COVID, you've had to move to a distance learning model. How do you teach competencies that way?
We're working with it and we're learning, but some of the basic competencies, there has been training in both countries, in Malawi and Sierra Leone, and there are trainers that can help to train the faculty so we don't have to cross borders. The use of videos, demonstrations, not just written content, has been helpful to some. So we're working with it, but we're switching to more local resources and support for the faculty or the trainers that are able to do it in country, but with support from mentors through a virtual methodology.
Great, thank you. We also have more of a comment in from Liberia, where they're training nurses and midwives in neonatal care. It's more of a comment, so we'd love to hear more, perhaps by next week, about how that has helped to improve newborn survival. And that does raise a question, how do we evaluate the effectiveness of these programs? Anyone from AID want to comment on how you look at that aspect? Teresa or Leah? How you look at the effectiveness of introducing, greater workforce competencies and capabilities?
I think this is Leah. Teresa, did you want to comment?
Well, I'll start, and Leah, please go ahead and add. But I think one of the points that I mentioned is also, using in service again, and participating in adverse event reporting, where you use that as a teaching moment. And I think those are really, really helpful ways of also evaluating. I think you need to have a very proactive professional association also, and supervision and monitoring and evaluation. That's part of accreditation and skills maintenance.
I think this is Leah. I think you also have to look at outcome data.
Mm-hmm.
And I think it's very important if you're teaching resuscitation, for example. It's of course important to look at your your testing, your competencies, but look at outcome. Is your 6-year rate going down?
Yeah, here is Ornella. We are in WHO working very much at the moment on developing standards for the care of small and sick newborn, and also trying to match those standards. They will be also ready very soon. And but we are trying to match the standards with the training materials, because we realize that many times in countries we are missing the details we don't focus enough exactly on those competencies that are required, at least for those interventions that we would like to promote nowadays. So it will be, yeah, these are, I just want to anticipate that we are working on that as well. So on the list, and this should be matched actually with the list of competencies. Of course, more specialize the cadre, more bigger, longer will be the list of competencies. But I think we can really create a list of clinical competence. I'm talking that match, you know, the minimal requirement for each level of care provision.
Thank you. I think we have time for one more question, and a very appropriate question about other aspects of the health system, you know, improving facility infrastructure, water and sanitation. We found in the case of Sierra Leone the importance of constant energy to keep oxygen concentrators going. So there are other aspects of the health system that also need strengthening in addition to the workforce. Anyone care to comment on that?
Well, I'm happy to comment. I think is so important, this aspect, because actually it can be really demotivating. If you are, I mean, you can have your best possible skills or receive the good training, etc., and then you are not able even to wash your hands, or you are not able to practice those skills. Can be very demotivating for nursing and clinicians. So it's very important to advocate also for having an environment that allow us to provide the care with quality.
Yeah, very important. And there's sometimes a jump just to purchase equipment or get, you know, the physical stuff in place, but it takes, you know, all the aspects of the health system to really turn this around. And even just getting, we experienced just having the location of the neonatal unit in the right place of the hospital makes a huge difference, rather than having it located far away from the delivery ward and other straightforward needs and approaches. But we recognize that the workforce alone won't accomplish this, but yet we need the workforce to also advocate for the improvements in the health system that will lead to the outcomes that they desire. I'm afraid we've reached the end of our hour and a half. I want to thank our presenters who've been fantastic, as expected, deep experience and a variety of perspectives on this topic. We will have the follow-up session next week, comparing current models of neonatal nursing education and sharing implementation lessons. In the meantime, if you want to share what you've been learning, you can email us at Ahmed and that's Aiden, who has been organizing this session at projecthope.org. We'll send that out so that you can share any other questions or recommendations in the meantime. But we look forward to seeing you next week, same time, same place. Have a great day. Bye-bye.
Thank you.
Thank you. Bye-bye.
Bye.
Thank you.